Reassuring thing here is that with CLEOPATRA paradigm, we know that we're stopping the chemotherapy at some point. It's time limited.
It lands up being 6 months just because of the neuropathy that happens with the taxanes.
Well, let's start by talking about first-line treatment for metastatic HER2-positive breast cancer, and specifically, let's talk about history, starting with CLEOPATRA. Dr. Jhaveri, maybe you could set the scene for us and tell us a little bit about CLEOPATRA, the long-term follow-up, and how it has established the first-line standard of care and where you see some unmet needs.
Yeah, no, absolutely. I think it's been over a decade since our practice has changed. We were very excited to have anti-HER2 therapy in metastatic disease, and we started using trastuzumab with chemotherapy when we learned that adding anti-HER2 therapy and chemotherapy together definitely was better than chemo alone. And then came along CLEOPATRA, where taxanes with dual HER2 blockade, including trastuzumab and pertuzumab, really beat our, the standard of care prior to that, which was just trastuzumab alone with chemotherapy. And for a decade, I think that has been our standard of care, given the progression-free survival benefit that we saw, which was about 18 months. But then we also saw very mature, follow-up data with over, 50 months of overall survival that we've seen past 5 years, or at the 8-year follow-up mark, if you will. And so really that has been our practice. The trial did allow us to give chemotherapy with anti-HER2 blockade upfront. And we did that up to maximal response or toxicity. It lands up being 6 months just because of the neuropathy that happens with the taxanes. And I feel like it's harder for us to then, push beyond that, even if we wanted to, for certain tumors to get more responses, because I think the neuropathy kind of catches up. But I think that also helps us then maintain the HP for many patients who might not require additional therapy. We stop at the 6-month mark, we continue the HP, and that's what CLEOPATRA did. And I think that has really changed how we had, been treating HER2-positive breast cancers. But now we have exciting newer data as well that has currently replaced or, shown us data that can replace this standard of care in the CLEOPATRA regimen, which is very exciting. So we'll talk about that very shortly, I think.
Absolutely. Well, that was a very nice summary. And I think, as you mentioned, for over a decade, we've been talking about the very high bar of CLEOPATRA, but certainly lots of room for improvement. And I think now we're seeing newer data, which suggests that the bar is adjusted. We'll get to that. But I want to go to Dr. Makhlin and ask you, in your experience treating your patients with the CLEOPATRA regimen, what do you see as the largest challenges? Dr. Jhaveri mentioned the AE profile, neuropathy, and so forth. But certainly there are other challenges, schedule and other issues. Could you highlight for us where you see CLEOPATRA in terms of its challenges and how that might identify areas for improvement?
Sure. So, I think we should start with the fact that CLEOPATRA mandated docetaxel as its taxane. And, practice has evolved over the last decade. We've seen some studies confirm that we can substitute paclitaxel, which in some ways can be better tolerated, in other ways it can be a little bit harder. We do deal with issues with counts with docetaxel, managing the neutropenia and the fatigue that we can see, which can be quite significant with docetaxel. And then with paclitaxel, Dr. Jhaveri already discussed the neuropathy, I think, which is the main dose-limiting toxicity that we tend to see, especially when we're giving weekly paclitaxel. The reassuring thing here is that with CLEOPATRA paradigm, we know that we're stopping the chemotherapy at some point. It's time-limited chemotherapy, and fortunately for many folks who are able to avoid the neuropathy, they then move on to HP maintenance, and they can have excellent quality of life for years.